We'll have two presentations of about 20 minutes each, and then we will open the discussion.
Okay, thank you very much. Good afternoon, everybody. Yeah, the title of the conference is very attractive: Sustainable Health Systems, Inclusive Growth. And we are talking already the entire day, and also during your presentation, Professor Cerniauskas, about how much money do we want to spend in the healthcare sector, and second question, what are we going to do with that money to get the maximum out of every euro that we spend in that healthcare system. Those are the two, well, there are more challenges, but those are clearly two challenges. I was asked to give a lecture on financing and organizing the EU health systems for the future. You could talk 2 days about that. I have 20 minutes, so I'll try to be concrete with some examples. And I must admit, I focus a lot on organizing, less on financing, because I was assuming that the next speaker would also talk more about financing. We'll see whether my assumption was good. Health economists make a lot of assumptions, and this was one of them. First of all, let's repeat our goal. What is the goal of our healthcare systems? We have to maximize the health of the population given the limits of the available resources. That's the goal. We have limited resources. We will never be able to do everything that we want. There will be always challenges to fight with others in the society that also need resources. And so within those limits, we have to try to do the maximum. And we have to do that in an ethical framework built on equity and solidarity principles. So we have the efficiency goal, do the maximum with the money, and the equity goal. And we proposed again to rephrase that goal when Belgium had the EU presidency, and the Council of Ministers also endorsed that statement. At least they signed that Council declaration. I hope they read it all, and that was the situation end of 2010. Okay, let's face the problems when we want to achieve that goal. I try to put them into 6 categories of problems. There is today still a lot of inequity in health and healthcare. More and more people cannot pay their healthcare bills anymore. So we see increasing health inequality, so we're not really doing a good job there. We see everywhere also overconsumption and overtreatment. We see a lot of wastage. We see even sometimes over-medicalizing people and so on. That's category 2. On the other hand, we see undertreatment. People who are supposed or asked kindly to leave a hospital earlier in a state where they cannot leave the hospital, but because of budgetary reasons and so on. Low quality, insufficient care. Then block number 4, we have lack of coordination. We still have a lot of fragmentation of care. And then the 2 more exogenous problems are changing epidemiology with the demographic changes and with more chronic diseases, more mental diseases. And then finally, what some people call the continuous technology push. There are every year new technologies, new medicines, new techniques and so on. And they seem to be always more expensive than the ones that we have already in the market. So that's also one of our challenges and one of the problems that we're dealing with. I come back to technology because I will also say something positive about technologies, of course. Those are the 6 problems, and we have instruments to do something about it. What are our instruments? We know them. We can set health objectives. We can create a growth path. Where do we want to be in 2030 with our healthcare sector? We can do that. There are techniques to do that. We can create better structures. We can create better processes. We can create new innovation models to make R&D and to make the development of new technologies more efficient so that they are not so expensive. Because why are they so expensive? Because those that develop them, they say, yeah, it costs so much to develop them, that's normal that we ask a high price. Well, let's try to make that development process more efficient. Then we can lower their prices. That's one of our instruments. We can improve patients' empowerment and responsibility. We should invest much more in prevention. That's instrument number 7. We should introduce better financing systems. Why not paying them to achieve goals rather than just paying them to do things? We should apply cost effectiveness everywhere in the healthcare sector. We don't do that today. And we should invest much more in a perfect e-health system that not only allows to communicate better between healthcare providers among themselves and with patients, but also to better monitor what's going on in the healthcare system. A perfect e-health system would help us also to do that. So we have 10 instruments to tackle those 6 problems. So we have kind of a health reform matrix. These are our problems. I don't mention them anymore. They were 2 slides ago. And you can have the slides so you can check whether it's complete. It's just a suggestion. We have the 6 problems. We have the 10 instruments. And then we can go and see which instruments can we use, or should we invest in our country more in that instrument to tackle our key problems? Because our problems are not everywhere the same. Some countries have bigger problems in block number 2 or 3, for instance, others in other blocks. So that's the idea. We have problems, we have instruments, let's see where we can match. That's the idea. Okay, I'll give some examples. One of the instruments that I mentioned was set a growth path for the healthcare sector. So, what we did, for instance, in Belgium, there is a think tank that said, guys, if we continue to grow as we were doing, we were growing about 4.5% per year. If we continue to do that, then the public expenses, this is public expenses for health, expressed in percentages of the GDP, that will become by 2060 30% of our GDP. So we will spend 30% of our economy on health, if we continue to grow as we did. So some policymakers said, maybe we should grow only 2% per year, as from now. Where will we end then? Well, the economy grows, the health sector will grow. This is where we will end, about 9% of public expenses, almost 10% of public expenses in function of the economy. But then we know that's not enough. If you only take into account the demographic change, then you need already to be, and you want to cover that demographic change. You still want to keep your equity, that all these elderly people who have a medical need also can have quality care, then you need to go about 13%. That was the calculation. And if you have to take into account that there will also be new technologies in the future. You cannot just assume, as from today, no new technology anymore. So demographics is one thing, but then new technologies, then we would end at least already at 18%. Now, there are some caveats in this calculation. Demographics, okay, how long will they live? Okay, that's what you call the longevity risk. How long will they live? But also, how long will they live in being sick? So what will be their healthy life expectancy in the future? Oh, that depends on technology. So there is a relation, of course, between demographics and technology. And those new technologies, how many of them will be cost-inducing? And how many of them will be like, there was a remark from the generics, is the lady still here? Yeah, so I mentioned you. So those are then technologies that can save money. So what will be the mix between those technologies that will induce cost and those that will save cost? We don't know, we can just estimate. But at least we have to try. If we don't do this, if we don't design a growth path, then what are we doing? In any sector in the economy, when you start to making a plan, the first thing that you do in your plan is to make objectives and to say, where do we want to be by then? That's what we have to do. So what do we get by that? Well, we will definitely tackle the problem of the epidemiology and the technology, because we want to take that into account. We want to calculate what will be the impact of those two problems. That's just one example. We have an instrument. The instrument is setting a growth path, and this instrument will tackle especially those two problems. That's the idea. Second example. So concretely, I mentioned it already, we will have to calculate, taking into account economic growth, demographic changes, impact of technology, and so on. And then, of course, we will have to monitor that growth path. Second example, we need to apply the principle of cost effectiveness everywhere. If we have the current situation and we look at costs and at health effects, then we know that many new technologies come in the market with an extra cost. But then we have to calculate what will be their savings. And sometimes those new technologies are what we call dominant. Their investment is completely compensated by the savings. We need to take that into account. We cannot afford any more people that just look at the drug budgets, or people just look at the budget for diagnostics. We have to look at the full picture, of course. Sometimes I must admit that saving is not so spectacular, that we still have the investment. The red arrow is still the net cost of the new technology. And sometimes think of the regenerative medicine that is approaching us. Regenerative medicine will cost money and will possibly induce money, because people will keep on living longer, and because they live longer, they will keep on costing money for the healthcare system. So we will induce costs. But that's why we have to look at the second dimension. If we then can show that we gain a lot of healthy life years, a lot of quality adjusted life years, only then we can come to the conclusion. And the conclusion can be either here, with the new technology is a dominant technology, saving money and more effective, or the new technology is up here, costing a lot of money and does not provide a lot of health, then it's not value for money. We should not adopt that technology. Or we are here, where yes, we will spend more money, but every euro is well spent. We have a cost-effective technology. Then everything depends on the threshold. I will not spend time today about discussing about where is our threshold, how much are we willing to pay for a gain in health, but it's clear that every country should set that threshold to better understand where do we want to be with our investment in health. So with this instrument, tackling and calculating cost effectiveness, we will do something about unnecessary care, because not cost effective care would then not be allowed anymore. We can do something about the continuous technology push, because we will spend money only on those technologies that have proven cost effectiveness. Otherwise, why should we spend money on them? That is, those two problems are then tackled with this instrument. So concretely, in drugs, many countries for drugs apply already cost effectiveness, but not in other areas of the healthcare sector. We should systematically apply it. And maybe not only new technologies, but also existing technologies that are already 10 years in the market. Maybe some of them are totally not cost effective, or they're not used in a cost effective way. We should tackle that. But then we should also set our thresholds. What is our willingness to pay? And that willingness to pay can even be in function of equity. In the Netherlands, they say our threshold is between 10,000 euro per quality and 80,000 euro per quality. 80,000 in those diseases where there's a high medical need, where the people are suffering a lot. There we want to pay more for investments in healthcare. And that's making sense. Okay? And then, of course, in cost effectiveness, there is the word effectiveness. We should first of all investigate what is the effectiveness of those new technologies. Let's not do that all of us separately. Let's not duplicate our efforts. Let's have a common European assessment of that effectiveness. It's not so difficult, and the UNETA is helping us to get there. Example 3, instrument of financing and paying healthcare providers. And I believe a lot in pay for quality. Pay for quality, there is a definition of the Institute of Medicine, but simply stated, it means if physicians or hospitals deliver better quality, they can earn more money. The better you work, the more money that you can earn. So let's stop paying them to do things, but let's start paying them to do the right things and to do the things right. Okay? It's two different things, but it's both important. They have to do the things right, and they have to do the right things, and then we can pay them more. Okay? Now, I must admit that it's not always so clear how to measure quality. Do you have the data? What kind of incentive do you provide? Is that incentive as such cost effective? And so on. There are confounders, but the principle of pay for quality is really important, and we have to spend more time and energy in it to apply it. I give the best example. There are bad examples as well, so my lecture is biased. I apologize, but there was a fantastic paper in the New England Journal, Reduced Mortality with Hospital Pay for Performance. They rather prefer the term pay for performance in the UK. It's about the same as pay for quality, not exactly. I prefer pay for quality, but the point is clear. By paying the hospitals based on their outcomes in terms of mortality, those with better outcomes got more money to reinvest in quality. They reduced the hospital mortality. So pay for quality, if it's done correctly, really can work. Concretely, well, I have only one concrete recommendation. We have a fantastic paper on this. Please read our paper. It's called Pay for Performance Step by Step, Introducing to the MIMIC model. And MIMIC means a model for implementing and monitoring incentives for quality. And we explain step by step how any country can introduce pay for quality in their healthcare system. Which problems can we tackle with pay for quality? All of these. I will not go into the details, but all the 6 problems that we have can be target of pay for quality. You can build in new technologies in your pay for quality and the correct use of those new technologies. You can set criteria for better coordination between healthcare providers and make them coordinate better and pay for them if they coordinate better, and so on. So pay for quality has really very broad potential. Example 4. We were talking already this morning about, yes, there is an increasing mix of Beveridge and Bismarck models. That's correct. I believe the situation ideally should be as follows, that in the first package of healthcare, we should put everything that is primary prevention, health promotion, screening, vaccinating, and also care for people with multiple comorbidities, and organize that as community programs. So I'm biased again. I live in a country with a health insurance system. But my point is that those people and those approaches, they need a national program. They need and then implement it in the communities and so on, there is enough evidence that health insurers are, for instance, not interested so much in patients with multimorbidities. And health insurers cannot do each by themselves health promotion programs. Those are things that we have to do in a community setting. And of course it needs to be cost effective. Not every screening is cost effective. We need to do this only for the cost effective ones. Package 2 should then look at all other types of treatment and prevention. A lot of acute care is in there, but which is not in package 1. And here there is a possibility for competing health insurers. There is also a possibility in those countries without health insurers for regional role of purchasing care and so on. And then package 3, that's the not cost-effective care. If something is not cost-effective and somebody who is rich still wants to pay for that, let him pay for that. He can, if he feels better by paying for that, I don't care. But whatever is cost-effective, we have to try to keep it in our package 1 and 2, that everybody can have access to it. That's the idea of the 3 layers, if you wish. And a part of that is then that in both layer 1 and layer 2, the GP has a crucial role. Barbara Starfield, every time I give a lecture about this, I always say Barbara Streisand, but it's Barbara Starfield. She showed in a fantastic review that in those settings where there is a stronger role of the physician, I'm not saying that there is a mandatory layer that everybody should first go to the GP. No, it's about a stronger role for the physician as the medical coach of the patient. Then you have less hospital admissions, less emergency visits, less non-evidence-based operations, less readmissions, and so on. So it really works, and we need to invest in better, a stronger role for the GP. And again, we can tackle all the 6 of the problems with this instrument. And concretely, it means that there should be a mandatory GP practice. It's more and more GP practices, not individual GPs, for every patient. And we should increase the payment per patient per year. A physician should not be paid fee for service, but a fixed amount per patient per year. In Belgium now, the average GP has already 20% of his income paid per patient per year. And we have to increase that. We have to increase the financial attractiveness. Ideally, a GP should be paid, I'm dreaming of course, but a GP should be paid more than a specialist. And the best MD students should become GPs. They should be selected and they should become the GPs. We are now 2013. I'm not talking about 2014, I'm talking about 2025, 2030. That's where we want to be by then. Final and most important one, we need processes to guide innovation. What do I mean? Well, we know that in many diseases, maybe in all of them, there are still value deficits. There are still people dying much too young. There are still people suffering much too much. So we have a development challenge. We need the industry to create products, technologies that add value, to do something about that value deficit. We all agree. Then we may have to make sure that these technologies not only add value, but they provide value for money. So we have the market access challenge. They need to convince us, the industry needs to convince us that what they are producing here is value for money and deserves to be paid by our public money. And then once it's in the market, we have the challenge about the correct use of those technologies. We still see overuse and underuse. We have the challenge about the right doses of that technology. And then again, the circle is round because there will still be value deficits and we need more technologies and so on. Well, what we need to do in the future, much more, is to seek partnerships between governments and the private sector. In the development challenge, there is a need for more partnerships to stimulate innovation. We still think, okay, the industry, let them do the development and then we wait until they get something for us. No, we need a public-private partnership much more, not only the Innovative Medicines Initiative, we need more public-private partnerships, sometimes one-to-one, in order to better do that development. We need public-private partnerships in the market access challenge to deal with the uncertainty at that point in time. And to come with contracts that tell us, okay, if you can show within this and 2 years that you keep your promise, then you can have so much money back, or if you cannot show your promise, then you have to pay so much money and so on. That can also be part of contracts. And then in the market usage challenge, we need partnerships to exactly stimulate that correct use of the technologies in disease management programs where government and companies work together to have optimal use of the technologies. Again, we are not at 2 different sides of the river. We have to work together to achieve the goals. By the way, let's not forget, and again, we can tackle everything here. I will not go in details. Let's not forget the definition of a PPP. It's a contract between the public sector authority, who always takes the initiative here in PPP, and a private party. And the private party provides a public service, delivering health, developing new drugs, and so on, and assumes a substantial financial, technical, operational risk. And the public authority provides some kind of support, most of the time financial support. That's a PPP, and we need much more of them in the 3 phases of that development cycle. So, conclusion. We have 10 instruments to tackle 6 main problems. And that means that we have this health reform matrix, and we can use that health reform matrix as a roadmap or as a dashboard to see what we are doing. I think that's very important. And of course, we have to do that within an evidence-based policy culture. We have to monitor what we are doing. That is also a circle. Doing health policy is also a circle, also checking what we are doing. And obviously, this was too generic what I was presenting, because every country must set its own priorities because it has other problems and other challenges. But I can use the same matrix to do that. And the ultimate goal for every country must be the same. Remember, maximize the health within the available money. And in fact, that available money, remember the growth path, we can plan our available money. We can decide how much money we will have available in 2015, 20, 25. And within that framework, we can try to do the maximum. I have to say a warning. I did not say anything about health determinants. I did not say anything about all these things happening outside the healthcare sector that have so much impact on health. Just one statement from Lowy: it's difficult to create a just healthcare system in an unjust society. And I know what I was telling here is only focusing on the healthcare sector, and there is much more abroad. But as I said, there is other opportunities to talk about the other aspects. I recommend everybody to listen tomorrow to the lecture of Professor Mackenbach, who will definitely say much more about this last point. So that was it. Thanks a lot for your attention. And also watch what is said here. That is, I think, very important. Thank you very much.